I am working as anesthetics, specialist anesthetics there in Dubai.
What is your specialty? Like, what is the area of interest? What do you like to do the most?
Most generally, I am doing the general surgical cases, mainly the operation theatre, running the operation theatre.
If Surya is too shy to speak,
Yeah, you will speak for him.
he was our support in Jabra Hospital.
Yes.
A perfect support.
There you go. Gagan.
Yeah, hello everybody. I am Gagandeep from Meerut, and I'm into active anesthesia practice as a freelancer for last 17 years.
We work together, isn't it?
Yeah, we work together. Shiv is
Yeah,
my senior,
so-
6 months.
So, yeah.
And,
So we all, Abhijit, myself, we were all together at AIMS, training at the same time.
I am Dr. Bharat Bhushan Bhardwaj. I did my graduation from GSVM Medical College, Kanpur, 4B and 5B.
What B and 3B?
It initially came to 3B.
Yeah.
It was by Dr. Anil Sharma, then 4B, and yesterday night only promoted to 5B. So
Can you elaborate what the 5 is?
that will be explained in the gala dinner. So I did my graduation from GSVM Kanpur and my MD from KGMC Lucknow. Since then we are working in group practice for last 8 years at Lucknow, looking after 4 hospitals. Primary area of interest is trauma and airway. And what I visioned last when we started the group practice is now being promoted in Lucknow. There are 2 more small groups that had come together in last 6 months. I hope that they come into full-fledged group and promote our anesthesia specialty.
I think that is the thing, isn't it? We learn from each other. Group practice for freelancer is the way forward. I think supporting each other is very, very important.
Hello everybody, I am Dr. Anurag Agrawal from GSVM Medical College Kanpur. I did my UG from Kanpur, PG from Agra, SRship from AIMS and fellowship in pain from BHU. My only area of interest is pain management. So, one and only actually, I don't do anything else.
Myself is Dr. Shishir Agrawal and I'm working with Dr. Bharat as a team in Samvedya Anesthesia and Pain Solution in Lucknow. And my area of interest is ultrasound guided regional anesthesia. Thank you.
Hello, I'm Dr. Alok Pratap Singh, working as an assistant professor in SS Medical College, Riva. My area of interest is regional anesthesia. Thank you, sir.
I'm Dr. Sushil Garg, a freelance anesthetist from Bathinda. My area of interest is WhatsApp.
Hello, myself Dr. Ajay Tikaria. I passed MD from SSMC Riva. My area of interest is regional anesthesia.
Hello, I am Vineet Gupta. I passed my UG and MD from Bikaner, Rajasthan. Then I came back to Delhi, and since then I am traveling every 3 years from one place to other. My area of interest is also traveling from one place to other. I started with facial-maxillary surgery and neurosurgery. Then my area of interest changed to the spine and joint replacement, then to the gynae obstetrics, then to the freelancing, then bariatric surgery and plastic reconstructive surgery, then to the aesthetics, and now I'm looking for something else. So, so now my area of interest is regional anesthesia. I will learn something and then I'll do something. Okay.
My name is Dr. Arun. Right now I'm working in Punjab in Namashahar as a consultant anesthesia. Thank you.
Hello everyone, myself Dr. Sunil Gupta. I have done my UG PG in Bikaner Medical College. Presently I am working in Kailash Hospital, Behrod. It's a multi-specialty hospital on Delhi-Jaipur highway, 125 km from Delhi. We basically deal in trauma cases.
I didn't introduce myself, so I'll take the liberty again. I'm Pankaj Gupta, practicing. I did my MBBS MD from BJ Medical College, Pune, and I'm practicing in Nasik, about 180 kilometers from Mumbai. My special areas of interest have been pediatric and neonatal anesthesia, joint replacement surgery, a lot of airway problems, a lot of laser anesthesia for ENT, and obviously obstetrics. It has been freelancing. Recently, after coming across some groups, I did form a group. We are about 12 anesthetists in a single hospital. We have distributed days and time to get to know how it works to work in a group. Thank you.
Myself, Dr. Ketan Joshi. I have done my PG and MBBS from MPSI Medical College. At present, I am at Jamkhambaliya, District Dwarka.
Hello, I am Dr. Dennis Patel, freelancer from Rajkot, Gujarat, area of interest bariatric surgery.
Hello, I am Amit Wagadia. I am also from Rajkot. I do my freelance practice, and I did my PG and UG from BJ Medical College, Ahmedabad. And recently, for the past 5 to 7 years, I am doing most work in the pediatric group of patients.
I'm Purnima Dhar. I am from Delhi. I did my undergraduate, graduation, post-graduation, and senior residency from All India Institute of Medical Sciences. And since '97, I'm working at Apollo Hospital in Delhi, and it's probably the oldest group practice in the country, I think. Chitra? Must be. So we've been together since '97. '96 actually the group started. I joined it in '97, and I strongly advocate group practice for all of us. If you want tips on how to make it work, I can give it to you.
Good morning, everybody. I'm Aparna from Delhi, an alumnus from Maulana Azad Medical College, Delhi. I did my PG from Safdarjung. Thereafter, I picked up my finer skills in anesthesia from Sir Gangaram Hospital, where I worked for almost 12 years, where I practiced everything from pediatric to organ transplant. For last 5 years, I have moved to Max Super Speciality Hospital, where I'm completely focused on laparoscopic and bariatric surgery anesthesia. So that is my current interest now.
Hello, myself Dr. Yuvraj Giri from place Hojai at district of Nagaon in Assam. I have done my PG and UG both from Assam Medical College, and I am now working in the hometown Hojai in Haji Abdul Majid Memorial Hospital and Research Center. And I am doing general anesthesia, regional anesthesia, also in ICU practicing. So I am trying to be all round. Thank you.
Hello everyone, I am Murli Raju. Basically a Tamilian, but born and brought up in Delhi. I did my undergraduation and post-graduation from Delhi University. Then moved on to working in an industrial hospital with NTPC for 7.5 years. Came back to Noida and did a couple of years of corporate institution-based practice. Then ultimately I moved on to Tata Steel and working in Dhanbad right now in the coal belt. My areas of interest is generally whatever comes my way, but I generally I've believed in regional anesthesia since long, and after joining this group I started doing a lot of it now. And my hobbies include music, dramatics, and cooking. Had I not been an anesthetist, maybe I would have been a wonderful chef, maybe.
Hi, I'm Dr. Chitra Chatterjee. I did my undergraduation from Maulana Azad and then did my post-graduation from UCMS, GTB. After that, I did around 8 years of cardiac anesthesia. And well, it was getting too much of one-to-one practice for cardiac, although I really enjoyed it as a subject. It's one of my very favorite areas. But then I found Dr. Purnima and her whole group in general anesthesia and moved on to general at the same hospital, Apollo Hospital, Delhi. And slowly again learned my spinal anesthesias and putting LMAs, and doing DNC was the most difficult surgery for me. I wanted to put arterial lines in every patient possible. And then over the last 5 years, of course, I've been doing liver transplants also and kidneys and everything. So it's been quite a nice growth, and as a group, we are a fantastic group, and it's really nice, fun working there. And my hobbies are painting and a lot of running and fitness. I'll be running the marathon this next Sunday. And that'll be, of course, my first marathon, so I'm a little apprehensive when I, drove down the same way. So it was lovely coming here and meeting all of you.
Good morning. I'm Dr. Alok Basuroy. I'm one of the few veterans rejuvenated by this breath of fresh air. A fantastic effort. I must commend all the organizers. I started my freelance way back in 1988. And over the years, of course, now have traveled a long journey and now in institutional practice attached to 2 hospitals, Pushpanjali Crossley Hospital and Tirath Shah Hospital. Dabbled into nearly everything, but now the area of interest narrowing down to oncosurgery. Thank you.
I'm Dr. Sudhakar Subramaniam, native of Tirunelveli, but right now settled down in Chennai. Graduated from Annamalai University and then was working in Apollo Specialty Hospital for about a year in Chennai. After that, I moved over to Singapore for a while, and that was where I was trained in neuro. And then I again moved back to Chennai, and right now I'm attached to, I'm with Surendranath and Pooja at SRM Institute of Medical Sciences in Chennai. And my hobbies include photography, wildlife, and a little bit of conservation, hiking, and the list is endless. Thank you.
Good morning, everyone. I'm Arvind Sivasundar from Chennai. My work is, most of the work I do now is obstetric. It's called Sitapati Hospital in Chennai, where we do mostly obstetric and some general surgery, as well as a lot of fetoscopic procedures. Thank you.
Hello, good morning everyone. I am Dr. Preet Kamal Narula from Bathinda. I did my UG and PG from MP Shah Medical College, Jamnagar, and my area of interest is regional anesthesia.
Myself, Dr. Chintan Vyas. I am from Bardoli, a small town near Surat. Working since 10 years. I am happy to say that I am the proud junior of our secretary Anil Bhai. I don't know how proud he is. I don't know how proud he is.
See, this was one guy who will be very enthusiastic in doing ortho in night because he can experiment with all the blocks. And as a senior sitting in the room till the call come from his side that, sir, all is well. It was not well for us at least. Let us be honest. But he has a very successful private practice, and I am really proud of him because a few people can experiment. We will be all worried about what will be the consequences and all that, and till some European publication comes out with the same thing, we are very apprehensive. So I really appreciate him for establishing his private practice, and I am really proud of him. So a word about myself. I am Dr. Anil, and I am very proud to be working with Dr. Purnima, Dr. Chitra Chatterjee, and obviously this is one of the best anesthesia group practice. And I'm really lucky to be in between you because of all of you for that matter. My hobbies are obviously cooking. It's a very big stress buster for me. And I think after this conference I can say that I have an alternate profession in events management also. Thank you.
Hello. Myself Dr. Hetal Vadera. I am coming from Rajkot. I passed my UG and PG from Ahmedabad, UG from Vijay Medical College and PG from NHL Medical College. Right now I am working in Sterling Hospital, that is corporate hospital. I did freelancing for 9 years and then shifted to this corporate hospital. Hobby is Facebooking.
When I was thinking of what should be a mascot for the anesthetist group, Hetal actually fits it very well. Golu Molu. He's such a friendly face. You see, always smile with him. Okay. And obviously, he's our treasurer. Okay, and absolutely, this has been possible because of two people. That is Anil for his organizing skills, and Hetal because of finances. These are the two main things. Okay. Yeah. And obviously, no conference would be possible without the delegates and the faculty. And thank you very much for being here. I have one more person to actually introduce, or let introduce, and she's sitting in the corner, Manisha. Manisha, actually, all myself, Manisha, Gagan, all of us actually trained all together. She was my senior at AIMS, and she will talk about herself. She knows a lot. She's just feeling tired because she just gone in last night.
I did my undergraduation from Delhi and MD and senior residency from AIMS, and then I went to UK. I've been there since 1995, and I specialize in obstetrics and thoracic and some orthopedics along with it. And my hobbies are reading and traveling, and I really don't enjoy cooking, so so yes. Yes, so those who like...
Does Kapil cook?
He likes to cook.
He's an orthopedician.
Yes.
Okay. Yeah.
He doesn't always. He cooks when he wants to.
Yeah, absolutely. Most of the guys.
And he has got a very surgical approach to cooking. He'll stand there with his hand. Can you hand me this? Can you get me ginger?
Anybody else? Is this other Suma? Oh, Srirang is there. Pallavi is also here. Yeah.
Good morning, everyone. I am Suma Ahmed. I am working as a senior resident in AIMS. I was initially in trauma center. Now I am in neuro anesthesia department, and my area of interest is neuro anesthesia and critical care. Thank you.
Suma, they were asking, "Ye Suma hai kya?" Yeah. Srirang. Yeah. All right.
Good morning, everyone. I am Dr. Abhinav Shukla. I have come from Raipur. I did my UG and PG from Bhopal. Then I moved to Delhi. I did my DNB from Gangaram and SRC from Maulana Azad. I am now working in Narayana Rudralaya Hospital in Raipur. We take care of the general OT and the surgical and the medical ICU. And we are doing neuro, cardiac, and general surgeries and a bit of bariatric surgeries.
Good morning, everyone. I am Dr. Rohit Bansal, belonging to Bahinda. Done my UG from DMC Ludhiana, my PG from CMC Ludhiana, then my DNB from Gangaram Hospital. My areas of interest are cardiac anesthesia, and I am presently working in a corporate hospital in Bahinda.
Good morning, everyone. I am Vibhu Parashar. I am from Motihari, small town in Bihar. I did my UG and PG both from BP Koirala Institute of Health Sciences, Dharan, Nepal. And after that, I worked as a senior resident in Ramanaloya, and then for 1 year in Medanta. And now I'm working back in Motihari at my own hospital, and started my ICU and practicing general anesthesia over there.
Good morning, everyone. I'm Dr. Divesh Arora, a graduate from AFMC Pune and a postgraduate from MP Shah Medical College, Jamnagar. And presently I'm working as a consultant in anesthesia at Asian Institute of Medical Sciences, Faridabad, a 350-bedded hospital. As one said, I take care from DNC till transplants and all. My areas of interest include quality improvement in anesthesia, and after joining this group, definitely ultrasound-guided regional anesthesia. Thank you.
Good morning. I'm Dr. Radharaman. I did my UG and PG from Allahabad Medical College. After that, I joined government service. I retired as chief consultant from Allahabad. Presently, I'm working with Indogar Fertilizers at Amethi. An area of interest is Surakshit anesthesia. And Surakshit this and Surakshit Marie.
Good morning, ladies and gentlemen. I actually entered medical college in year 1970 and been there. Okay.
What makes exam senior over here? 74 you passed out.
Yeah, 74.
I passed out on 75.
Yeah. So 70 I entered in LLRM Medical College Meerut, and for a year I went to Day-1 Medical College for house job. At that time PG used to be separate than house job. So I did house job in pediatrics and anesthesia and finally settled for anesthesia and chosen over it. After doing my PG, I worked in Hindura for 1 year as a registrar. Then I moved to Nigeria and I earned some nairas and dollars there for about 8 years. And then I decided to spend in rupees, which was really a pleasure at that time because salary was only 1200 in Hindura. And there I was getting 25,000. So that was a big leap. After coming back from Nigeria, I joined Tata Steel. And Tata Steel is in Jamshedpur. It's a big plant. And we have two Tata's hospitals there. One is Tata Motors, other is Tata Steel. They're all, both of them are 890 bedded. More than 800 Tata Motors and ours is 890 bedded. And I superannuated in January this year as a senior specialist and OT in charge. And to tell you more about Tata Steel and our hospital, that it was chief was anesthetist. Dr. Bire, he was heading the unit. Whole hospital he was heading. Then Dr. T.P. Madhusudan, he was heading the whole hospital. And I was in OT in charge. The anesthetist is in charge of ICU there, Dr. G.P. Samadar. Many people may be knowing him. And you know, it was pleasure kind of a thing that anesthetist used to write appraisal for the surgeon. So their increment was decided by anesthetist, other way around. Thank you very much. That was the beauty. Thank you.
Good morning, the anesthetist. I am Dr. Deepak Sharma. I did my MBBS from Nayaab, Mumbai and PG from Indore. Currently I am working at Janki Kund Hospital, Chitrakoot. It is a big trust hospital, a very famous place for eye surgeries. They conduct around 1 lakh plus surgeries every year. Well, I'm not involved in all. There I'm doing everything. Yeah, I'm sole anesthetist over there, and there we are doing everything other than cardiac and neuro. And my area of interest are critical care medicine and pediatric anesthesia. Pediatric, currently I'm working, and even I'm ICU in charge over there, but the ICU is very preliminary. It cannot be called as an ICU. It is sort of recovery room. I think before doing that I have to learn because I'm zero in critical care, frankly speaking. Thank you. Yeah.
Good morning. My name is Dr. Vijay. I did my undergraduation from College of Medical Sciences, Bharatpur, Nepal. Then I moved to Delhi. I prepared and then I got selected. I did my post-graduation from Pandit Jawaharlal Nehru Memorial Medical College, Raipur. Then I came to Hyderabad. I did my senior residency for around 6 months. I got selected. I did my PDCC neuroanesthesia from Sri Chitra. Again, back to Hyderabad. I am working in Yashoda Hospital, primarily taking neuro, but I wanted to do every cases. And my interest is anesthesia, anesthesia, and anesthesia.
Good morning, TOS family. My name is Dr. Srirang Rao. I finished my UG from MRMC Gulbarga, Karnataka, and MD anesthesiology from SDMC Kolar. I finished my MD in 2014 May, and I joined Yashoda Super Speciality Hospital, Hyderabad, as a registrar in Department of Anesthesiology.
Good morning, everybody. I am Dr. Sumit from Delhi, and I did my graduation, post-graduation from Ampisha Medical College, Jamnagar, and I'm doing freelancing in Delhi only. And the area of interest is regional.
Good morning, the family tech on TAS, the anesthetist. Vijay again, Vijay Sahitya. I did my undergraduate and postgraduate from the same institute, Sri Ampisha Medical College, Jamnagar, and under the same hands I was trained under Sumit Setia. Right now I'm working in Bahrain in the King Hamad University Hospital in anesthesia and ICU. Thank you.
Good morning, everybody. I am Dr. Munish Garg from city of Karnal in Haryana. I did my undergraduation from Rohtak Medical College and then did my PG from Ahmedabad from NHL Medical College. For about 6 years I worked in Meerut in Bharati Institute of Medical Sciences. Now currently I am practicing as a freelance anesthetist in city of Karnal. My hobbies are traveling, running, listening to music, and my special area of interest is regional anesthesia. Thank you.
Good morning, everyone. I'm Dr. Shikha Anand. I've done my undergraduation from UCMS, my PG and residency from Safdarjung. Right now, I'm working in Alchemist Gurgaon.
Good morning, everybody. I'm Dr. Pallavi Lande Margade, originally from Mumbai, now working in Amravati. I've done both my MD and MBBS from KM Hospital, Mumbai. Then moved on, I did my lectureship for 3 years in KM. Then moved on to Apollo Hospital, Chennai, where I did my PDCC. Then again, I moved to UK, where I did my FRCA. You can guess by now I'm married to a cardiothoracic surgeon, so I'm moving around with him. And finally, I'm settled. And right now I'm having a lighter job. I'm working as assistant professor in a medical college in Amravati. So hoping to move on from here.
Thank you. Thank you very much, Pallavi. Anybody else we left out before we go on to the next session? I don't know who I am. Anyone left? Sorry. Oh.
Hello, I'm Dr. Saad Kadwai. I am basically from Lucknow. I did my graduation and post-graduation from Aligarh. I'm right now in Riyadh. Yeah, I'm presently working in general anesthesia, but it involves all kinds of pediatric anesthesia, including premature babies. Yes.
દિલીપ સિંહ પરમાર નડિયાદથી આવું છું યુજી પીજી બધું મેં બીજે મેડિકલ કોલેજ અમદાવાદથી કર્યું છે માય એરિયા ઓફ ઇન્ટરેસ્ટ ઇઝ વેર ઇઝ ધ મની
Hello, I'm Arun Mehra, graduate of UCMS and postgraduate from Aligarh. And after that, I have also done an MBA in healthcare management from the Faculty of Management Studies, Delhi University. And you know, I'm asked for consultation and such things from different institutions. Well, I think my introduction can be, among doctors, I'm known as a writer. And among writers, I'm known as a doctor. And I'm a proud junior of Vivek sir, working in Saroj Hospital.
I am Dr. Sanjay Prakash. I did my UG and PG from Mahatma Gandhi Institute of Medical Sciences, Sevagram, Wardha. After that, I did my SRship from RML Hospital. And currently, I am working in Orchid Hospital, Janakpuri. And my area of interest are obstetrics and general anesthesia.
I am Dr. Ankit Chauhan from Ahmedabad. I completed my UG and PG both from Ahmedabad. Moved on to Apollo Ahmedabad as a senior registrar for 2 years. Then went ahead and did my fellowship in transplant anesthesia from SGPGI Lucknow.
Then again from there I worked in Medanta in Delhi for 1 year as an attending consultant in liver transplant team. Now I am again with Apollo Ahmedabad as a consultant in transplant anesthesia and neuroanesthesia. Area of interest is again transplants primarily. I'm working with neuro and bariatric also. Yeah.
Great memento for us, actually, for you being here. And we move on to the next session. We'll start with Piyush. This is session on ultrasound and echocardiography in the ICU. एक मिनट को ये इससे आएगा ना. It's gone into, I think, hibernation. Okay? Yeah. Okay. On public. Okay. You know my name? Okay, I did. Yeah. I actually did my undergraduation from Jipmar, Pondicherry. Dr. Prema is my super senior. And I did my PG with Manisha, Gagandeep, Abhijit from AIMS. I finished my senior residency. And then in 1998, I moved to UK, and I've been in Liverpool since then. And I've got my friends from Liverpool here. Senthil is there, and Tushar. So, and I've been in Liverpool. Pooja has visited. She was supposed to come and see our hospital, but got accosted by the other hospital, Aintree Hospital. She never got opportunity to be to our hospital. But all of you are welcome to Liverpool. Whenever you are coming to UK, please give me a call. You can message me, and you're most welcome to visit me. Thank you.
I will give a small thing for him.
Oh, thank you.
The most cordial person I have seen.
Thank you. Thank you. For the next session, can I quickly invite Dr. Hazim Dazi and Nevin and Dr. Hassan. Dr. Chawla was supposed to be here, but he had to go to Sir Gangaram Hospital, so we don't have him here. This may not interest everybody who's not doing ITU, okay, but I'm sure it'll be very interesting, because even though we are, as anesthetists, we may not be doing the echoes, but we do actually come across reports, echo reports, or we have started using ultrasound more and more, and that's what we're going to learn from Dr. Hassan and Dr. Piyush.
Thank you. I think 2 minutes to start. So, bedside ultrasound and echocardiography in ICU. Actually, what I have done is, this is not an ICU topic. The future of anesthetist, the movement is going from subjective to objective evaluation. If you can do something, why not? And it is doable. And he is the man who is sitting there, who taught me all ecos, basics idea in 7 days. First 4 to 5 days, you will be frustrated. You will be seeing something and imagining something. But it has got a learning period of 1 week, only 1 week. So you can then have an idea, then sky is the limit, wherever you want to take it. So echocardiographic, all those parameters, what I am going to tell today, was initially taught by him. And so basically what I am trying to say is there is no escape. Even a good anesthetist has to, we have started doing nerve blocks. Just change the probe and try to see. I mean, if you can see a good squeezing heart, it's no need for a cardiologist to say you that segment 60. You know it's good or bad. We want that, all right? So basically, what are the common uses? You put central lines, you put peripheral cannulations, nerve blocks, arterial lines, acute and chronic pain management, spinal epidural space identification, difficult spine in obese patient. A big thing is the lung ultrasound, which is a I mean, it's not new anymore, but you name it, lung is better than your chest X-ray. I mean, ultrasound is better than chest X-ray in everything. There is, as I said, there is a learning curve. There are some ICUs in Europe, I have seen myself, they don't do X-ray chest. The junior most guy comes and do ultrasound and take a printout, put it there, A line, B line. You just, from that you can have an idea for everything. DVT, PE, MI, which area, is it MI, the ECG, I mean, you do it with your ECG and you will get to know what is happening. Now, another big thing is patient comes, our big worry in emergency medicine, patient came with gasping or dyspneic, we don't know history, or history is not very clear. Just by putting a probe in less than 1 second, you can categorize the patient whether it is a COPD type of heart, dyspnea or a CHF type of dyspnea in 1 second. So tell me a tool which can give you this. I mean, I'm telling you the fastest. Okay. So fast exam, ocular ultrasound. I do a lot of ocular ultrasound, not for seeing or diagnosing any eye disease, for optic nerve sheath diameter to know exactly what would be the intracranial pressure, because just remember a number 5.8. If it is more than 5.8 millimeter, there is quite a fair chance in the clinical scenario that would be intracranial hypertension. With transcranial Doppler combination, it becomes more sensitive. In fact, in our hospital, they have having a business plan to not to do lumbar puncture, to find out what is the pressure in the brain and do it non-invasive. This will be the first time in the world. So anyway, E-fast, abdominal ultrasound, not for diagnosing cholecystitis, for IVC collapsibility, which can get, you don't need to put a CVP if you have a good view of IVC and its collapsibility, it's enough. I mean, there is gradation 50% collapsibility, your CVP would be 5 to 8. More than 50%, less than 5. Give fluid, see again, and just 20 seconds each time till you optimize it. So how much fluid? The big thing is no need to put a Swan-Ganz catheter, which has gone out of favor, but we used to do it. Had it been taught 10 years back, we would have gone before. I mean, you just put a probe, get a view, see the aortic valve area, calculate the size of aortic valve, and take a tracing. It sounds big, but actually, I could do it on my 7th day. That is called VTI. Sounds big, velocity, time integral. The easiest thing ever you can do. Okay? You have a VTI. Your VTI and my VTI is around 30. Hypertensive pulmonary edema comes, you see a VTI of 10, 9. You give nitroglycerin, it goes up. It's like a dynamic thing. You just you see the patients getting treated, and one VTI reading, just one VTI reading, you know the valve area. Each time 30. My VTI is 30, and my cardiac output is 5 liters. And you don't need to do any calculation. Now VTI is 30. Now VTI is 20. We know how much is there is scope of improvement. And again, the respiratory variation you can see. Same thing of pulse pressure variation, stroke volume variation. You can see them in the monitor blind. Here, you can see them in reality. It's more objective. So, so systolic function, diastolic function, left heart or right side of which is causing problem, cardiomyopathy, whatever. Another thing is that now CPR guide. Tell a person who knows ultrasound probe how to put it in the diaphragm. Just, scooping type of motion, you just try to see some part of the heart. Are we doing a proper CPR? And each time we see patient came back or not, monitor seeing ECG, whether it is a electrical, there is a conducted rhythm, it's good. You just see it there and then. Heart is started beating, move out. It's a good contractile heart. You don't need to palpate. I mean, how many times we missed carotids and all those things and hypotensive. You can see the heart contracting there. And you can see the CPR quality there. So all these things. Anyway, TACON. Big boss has asked me to speak about this. Lung ultrasound, intravascular status, bedside LV-RV function, cardiac tamponade, dynamic LV obstruction, Takotsubo cardiomyopathy. Just remember this odd name. It's a Japanese name, Takotsubo cardiomyopathy. Not all MIs are MIs. Not all chest pain are MIs. Not all ECG changes are MIs. There is, they are started saying, any conference you go, they will speak about this. Around 3 to 5% of all MI were being misdiagnosed, mistreated. They were Takotsubo cardiomyopathy. What happens? We'll just have, basically the apex of the heart balloons out. It's an echo diagnosis to start with, and confirmation comes from angiography. So ultrasound of the lung, pneumothorax, pulmonary edema, pleural effusion, pneumonia, dynamic air bronchogram. This is a big thing, that the air bronchogram of X-ray, which tells us that there is an infection. What if you can see those things dynamically? I mean, it is more sensitive. Of course, ultrasound is more, just to let you know that small anterior pneumothorax in an X-ray chest, in overall, patients are around 40 to 50% sensitive and specific. I mean, it flip of a coin. But ultrasound is approaching CT scan values, if you know how to do it. So basically, it is 97% specific. So, and you diagnose much earlier without radiation, double advantage. So this is it. Now this is A line, repetitive, horizontal, reverberation artifact. This is called A line. And that one, once it starts, it's called B line. So it is an equidistant, 7 millimeter distance between these lines. And look at what happens. Then the same patient, suddenly, the distance will go away and all like 1,000 B lines, like, it got coalesced and mixed up. I'll tell you, A lines are normal. If a patient of dyspnea coming with this line, this patient not doing fine, saturation is going down, it's very likely that this patient is of COPD. It cannot be pulmonary edema, because pulmonary edema was there in the right lower corner. Pulmonary edema looks like this, the right lower corner. Once again, the COPD looks like this. Suppose the patient is normal, I mean, he's not dyspneic or anything. This A lines are normal. Normal present in you and me, anybody. But COPD, you might see a very bright and this lines, and basically B lines is for blood, blood is a fluid. So remember, B line is for fluid or liquid, B for blood, A for air, air, full of air, COPD lung, A lines. So which kind of lung is this? There are only two kinds of lung, predominantly A line, predominantly B line, like two ventilation modes. Okay? So what happened? Remember curly B lines? These are what curly B lines you just saw now. The 7 millimeter equidistance thing was the same curly B lines on the X-ray. Exactly. Why 7 millimeter? Because intra-alveolar septa is 7 millimeter. This means this patient is having an impending pulmonary edema. The fluid has not gone inside to the alveoli yet. If you catch them here, in this stage, just they need BiPAP. But, after some time we delayed, fluid in the alveoli, and it goes in a sudden rush. So you have to put a lot of effort. It might take time. So it is intraalveolar or intraalveolar septa. So this is what the all lung ultrasound based on. Next, move on to pneumothorax. Which side? Pneumothorax. Left or right? This is positive for pneumothorax, and that is negative for pneumothorax. Again, there is no sliding. You see there is a small ant marching, or whatever you call that, lung sliding. This is the visceral and parietal pleura. Yeah, visceral. Here there was some sliding, and there was no sliding. We'll go. This needs a, this is from the day one. You can see it. Day one, sliding and non-sliding. Our lungs are sliding. Now, Sky Ocean Beach, they name it differently, barcode and all those things. But you put a M mode and see it. What is happening? M mode is a motion mode. Anything that is mobile under ultrasound appears granular. So anything, and air is the enemy of, even if 1 ml of air is there in between the vesical pleura and parietal pleura, it is not going to show anything. So here, if you see, as I said, it's a motion mode, M mode. This is negative because everything that is mobile, lung was mobile. So there was granular. This was granular. When you see this, it cannot be pneumothorax. Look at what happens. So this is for negative for pneumothorax because there was a motion. Had it been 1 ml air in this range, this is the visceral and parietal pleura, 1 ml, because ultrasound cannot pass through air. So it is not be visible. So what this, taking this advantage, they have used this, like, you see, this is like straight line, straight line. So below pleura, lung is not moving. Sky, ocean, and there is no beach. There is no granules, there is no sandy beach. So basically the sandy beach is not there. So again, it is positive for pneumothorax. When basically static structures, M mode, it appears as a straight line, principal is this, and which is mobile, it appears as a granular. So again, it's like, lots of lines, no beach. So this is, I would not say that from day one you diagnose this. Day one you just see that I am seeing no sliding. Get an X-ray, confirm it. Day two you go for M mode and see, take an X-ray, confirm it. Believe me, after day 5 or 6, you will be expert. It is so easy. It's everybody's lung can be visible. So here granular, negative pneumothorax. It is straight line, positive pneumothorax. Pneumothorax is easy. Easy. There is lung point, lung pulse and all those things. We will discuss all those things in detail because we don't have time in forum. Everything can, I think Hetal has recently posted a lung point video, very nice one. All right. So we know now that the ultrasound is more sensitive, better than X-ray. It's approaching almost CT scans sensitivity. Now let's go to lung, pericardial pleural effusion, all those things you can now, lung, parasternal lung, heart would go directly to echo, parasternal long axis, short axis, 4 chamber, 5 chamber, subcostal view. For those who are not very aware, it sounds big. Actually, it's putting a probe somewhere and rotating here and there. These are the name given. So from this place, you can get the parasternal short and long axis. From this place, apical 4 and 5 chamber. There are only 3 places. For us, we don't want any high fighting. We do not want segment 16 hypokinetic. We want to know whether it is good heart or bad heart. That's it. So this is a good heart. It's a cartoon which is without the right ventricle. This is right ventricle I have taken out to get better understanding. So this is the mitral valve. Once again we'll start. Again, this is the mitral valve. This is the aortic valve. So inflow, outflow. If you can see these 2 things, you are golden to start with. So basically, wherever you are going to put, some view will be like this. So see what is happening here. Mitral valve is closing and opening. And this is the outflow tract. And this is the mitral valve. For us, I will tell you a simple tool to diagnose. You can be better than a cardiologist in diagnosing ejection fraction from here. Okay? So you see, there is something called anesthesiologist estimation of ejection fraction. If this mitral valve goes and touches this, ejection fraction is more than 40%. That's what we want. Okay? If it touched, khalas. We know that ejection fraction is more than 40. It's a good heart. Okay? So you see again it's smart. This is what we want. And if you are fancy enough, you can put a M mode and see that how much distance it is about to travel. If it is 1 centimeter, then ejection fraction is less than 30%. Be careful. That's it. Good heart or bad heart. So this is what is all about. And you can put a M mode anywhere. You can do those, calculation. We'll do it. But this is the anesthetist. I call it EPSS, E-point septal separation of mitral valve. So if touching, ejection fraction is 40, 50, whatever you can write. It's normal. If it is not touching, then there is a problem. And how much is the distance? You measure the distance. Kitna baki hai? If it is less than, 1 centimeter, still it will be good. But if it is more than 1 centimeter, the heart is bad. You can think of ejection fraction of less than 30%, 25%. All right. Same thing. We see an example. See the mitral valve. What is happening? It's going, not going or smacking. There is a distance to travel. Good heart, bad heart, bad heart. Now, the cardiologist has never told us that this particular area, if you are seeing, which is supplied by which is artery. Once again, if you see carefully, this area is not moving. And let us see which artery supplies that area. It's circumflex. The circumflex artery is this area, and if it is not moving, that should be something in 1, AVL, and V1, V2. So in this way, you can improve yourself. So basically, this heart was not good. Number 1, mitral valve was not touching, so ejection fraction was less than 30%, and there was an area of this thing in clinical scenario of pain, chest pain. It's a MI. It's a MI of entry wall. I mean high lateral wall. All right. So same thing. We got the view from left parasternal long axis view. In that, we just rotate our probe to the counterclockwise. Just opposite. One was the right shoulder. Now this is left shoulder. If you put the probe on the that same area to other direction, you get a view of aortic valve. If you tilt it towards up, then you go to the mitral valve and papillary muscles. This is mitral valve. Tilt more, you go to. You can see through the aortic valve. And let me tell you, it sounds difficult, but it is not, because if I can learn echo in 7 to 10 days, we all can learn. And if you have an ultrasound machine for nerve block, please use it, because it has 3 probes. One cardiac probe will come free. Use it, because you will all have nerve block. So anyway, so here in the papillary muscles, here, you know, this is again papillary muscle view. Here you put the M mode. If you want accurate, ejection fraction, you put a M mode here throughout. And how much squeeze? Basically, you can see roughly there is more than 50% reduction of the size. So basically, eyeballing, you can see that this heart is a good heart, and there is more than 50% ejection fraction. Just to let you know, for Mohan and those who are a little bit, this area is supplied by LAD. This one is RCA, and this is LCX. So if you are seeing a motion, which is, motion means the contractility, the heart wall is not thickening. Regional wall motion abnormality is something different. It's not a motion abnormality, it's a thickness abnormality. When we go to systole, the heart wall thickens. If there is thickness is not there, that is called regional wall motion abnormality. The akinesia, dyskinesia comes later on. So it's all about concentrating on thickening of this thing. So this is a normal contraction. More than 50% of ventricle is contracted with each beat. So ejection fraction is more than 50%. So this is from the parasternal short axis. Now this is 4-chamber view. You keep your probe in the same mid-axillary, mid-clavicular line, half an inch medial to the apex beat area, and try to go through the apex. Basically, probe is here, and you are seeing this is called 4-chamber view. You twist and turn in this area, and you get the aortic valve in the picture. This is 4-chamber, this is 5-chamber. So this is what you do, how to get the 5-chamber. This is all about, automatically your hand will go. You no need to tell that move right, or, automatically you will search and get it. Believe me, if you get a parasternal long axis view, you can get all these views. But its initial, it will cost you 5 days of frustration. If you can sustain that frustration for 5 days, you'll be golden throughout your life. You don't need a cardiologist. Okay?
Every time you are telling the same thing.
Sorry, sir, no, but that is true. By the way, I don't call a cardiologist unless it is medical legal issues. He knows it. And he tells me that if Piyush is there, khatam karo wahi pe. Let me, I will sign it. So this is...
That is true.
Yeah, so this is one more view. You put a probe on the xiphoid process below it, and you try to squeeze into the heart. So you just see the heart through the liver. This structure, what you are seeing, is the liver, and very clearly you can see the RV. RV comes first, and LV. If there is emphysema and the patient has trauma, surgical emphysema, as I said, ultrasound's enemy is air. One drop of air will never let your ultrasound beam go or see anything. So that option is go down and see the heart from down. So case 2, which part is not moving? This is moving, this is moving. Look at the tip, tip is not moving. And we just told that, we just discussed the tip is supplied by LAD. RCA is okay, LCX is okay, LAD is widow's artery is getting involved. You check for V4, V5, V6, you get a ST elevation there, if it's acute ST elevation MI. It is that easy. So basically, you're finding, or in a patient who has MI, you have ECG, cardiologist has got diagnosis, go there and play around with your ultrasound machine, get to know. That's what, reverse way. So diastolic function, what we are talking till now was systolic function. So diastolic function is a big thing. You will be surprised in critical care world, the diastolic heart failure is it's a big area. Now they are saying almost 50% of heart failure are diastolic heart failure. That means if cardiologist has written ejection fraction is 50% and patient is not looking good, don't feel good, because he has not mentioned anything about diastolic heart failure. This is called preserved ejection fraction heart failure. Heart failure with normal ejection fraction, HFnF or whatever, So basically, just reading an echo, this is little bit of advanced stuff. So what I'm saying, the second step will be this, and I am doing it, so I am not that talented. So basically, we all can do it. So this is diastolic heart failure, M mode, tissue Doppler, and pulmonary flow pattern. There are 4 varieties of diastolic heart failure we can discuss in the forum. Now, cardiac output estimation. This is a long story. I mean, we had surrogates from Vigilio, Pico, Mico, whatever, name the monitor. They try to measure the cardiac output. But let me tell you, this is the gold standard. Nobody mentioned it because they don't know how to do it. So if you can do a cardiac output estimation in echo, this is exactly what you are seeing. It cannot fool you. If you are getting a good view, a good VTI, which we finished it. So basically what you do is this. You find this area, aortic valve area, measure that aortic valve area. This is the formula. You don't need to put this, remember formula. The machine will calculate you the cardiac output in seconds. So you just have to align your beam, one of the Doppler switch you have to press called pulse wave Doppler. This will give this. It's called VTI. Okay, velocity time integral. Once you get one VTI, your cardiac output is done, because you know the valve area. The machine will calculate everything. Now you are seeing this VTI is smaller than this. We'll go to the next slide.
7 minutes.
All right, sir. I'll take 5.2. Okay. So this is the VTI. So one is big, one is small. This is the pulse pressure variation. This is the pressure. This is respiratory variation of VTI. This is the same thing, a pulse pressure, systolic pressure, or stroke volume, whatever you call. This is exactly stroke volume variation in your eyes. What you are seeing, Doppler never lies. Me doing, you doing, Dr. Hassan Khan doing, this stress has to come if the patient is hypovolemic. If there is more than 13% or 14%, say 15% to memorize better. If there is a 15% increase or decrease in these two values, you can give fluid to make all those VTI same. So this is real. I mean, if you can do it, you're golden. So again, another tool. As I said, you don't need to put CVP. You have 2 peripheral lines. You want to see this patient's IVC, inferior vena cava, through the liver, and the probe is there, just little right side. You see this is the right atrium, and you measure this is the hepatic vein. You see how much percent? It's almost more than 50%, and sometimes it's touching, right? It's 100% collapsibility. This patient needs fluid. No rocket science needed. So, this patient needs, till what? Till the respiratory variation or the variation becomes less than 30%, stop there. And along with that, if you know how to get a VTI view, one view, and one trace, I mean, it's finished. I mean, your cardiac output and real time you can, get it. A little bit about right ventricle size. Right ventricle is smaller than left ventricle. Right ventricle is smaller than left ventricle. Right ventricle is smaller than left ventricle. So you have to, how much? It's 2/3, 1/3 smaller. I mean, 1/3 less. Contractility, less contractile, because it has to pass through a pulmonary circulation which has a low resistance. TAPSE, okay, tricuspid annular plane systolic excursion. Big name, small work. I mean, you just put a M mode over tricuspid valve, what you get is called TAPSE. All right? S prime, again, big name, same, you just do that in tissue Doppler. So normal values are this. Just remember this if you can. If you are doing a TAPSE, 25 to 35 is normal. If less than Mohan for you is 16 or less, TAPSE is bad. I mean, there is a contractility issue is going on. Septal motion and macronal side, I'll show a video for that. Deceped LV, we talked about this PE today morning. If you are seeing a left ventricle which is deceped, that means the septum is getting pressed towards the inside. It has to be something from the right ventricle, and there is some obstruction in the right ventricular side which is pressing the septum to become, the circle to become D. So deceped LV, and at that time if you can do a IVC, IVC will be anaconda-like, plethoric IVC, full IVC. All PE patients, those who are hypertensive, those who cannot take into CT scan, those who need thrombolytics there and then, and heparin did not work, still the saturation is low, hypertensive. You need to do something more. Probably thrombolytics, give him a chance. On arrested patient, you saw a right ventricle bigger than the left ventricle with McConnell sign. What is McConnell sign? Okay, let's finish the TAPSE. This is how you do it. You get a ventricular view, you put M mode over there in the tricuspid valve, you get this. If more than 25, it's normal. Less than 25, it's not normal. Again, the TDI, tissue Doppler. Again, you put the tissue Doppler, just pressing a button, the same switch, same thing, just you are naming it differently. This when it is less than 10, there is a problem. So we are going to see the pulmonary embolus picture again. This right ventricle is bigger than left ventricle, not normal. You see the right ventricular apex is moving like, very fast. This is hyperkinetic, but here, even though it is looking hyperkinetic, it's not able to contract anything. It's not squeezing. It's the same. The distance is the same. All right? With a hyperkinetic apex, with a non-contractile, and the 50% reduction is not there, what you saw was here. See, left ventricle of the same patient in the other view, it is 100% collapsing, but here, it's not able to touch, not able contracting. And plus, the apex is, this is called McConnell sign. They say it is pathognomonic sign or whatever. I don't believe this, but once you see this, and the patient is collapsing, right ventricle is bigger than this, IVC is full, you better thrombolyze him. Otherwise, he's not going to do well. And the same patient, this is a real patient, and the same patient, we do all femoral block. This is femoral block view. This is the artery, and this is the vein. You can see the vein is 100% collapse in one side. Look at what happens to other side, okay? Femoral profunda femoris, and don't try to search the femoral nerve here, but so here the other side of the leg, huh? You see, artery is compressive. I'm pressing too high. Artery is getting compressed, but vein is not. This is the bugger which caused it. A part of it has gone up. Same patient, real patient, and Dr. Hassan Khan thrombolized him, and he was operated case of spine. Just 1 day post-op, and he bled from, he's a paraplegic anyway. He told me that he's going to die anyway. Give him thrombolytics. What will happen? He will bleed. He had a big hematoma, again re-explode, and done. Anyway, he was paraplegic, but he survived in the ortho ward. Yes, sometimes you take a decision against guideline, but it works. The patients survive. Okay, we'll see the pericardial tamponade. This was a real patient, stabbed injury, and he's basically, I'm going to next slide. So we know that what happens to the this is swinging heart, tamponade physiology. You don't get this picture always, but I hope the ECG will come here. Yeah, you see electrical alternance. One is here, one is big, one is small. It's in the echo machine itself. If you put a probe, you can, this thing, he was stabbed, he arrested, we tabbed, he got out of cardiac arrest, and they did the surgery. He had a big tear in the pulmonary artery, pulmonary vein, so he could not make it. Now, hypertrophic cardiomyopathy, basically, in this view, you measure this distance. So remember, 1.5 centimeter. If it is more, then it might be a hypertrophic cardiomyopathy. So this is how it look. They call it SAM. Okay, can I take a one minute? Sir, this is Sam. Okay, I hope it works. So basically, if you see the mitral valve, you know, it's getting bent. I don't know, it stopped. Okay, see here the mitral valve, instead of coming down, it's going up. So it is obstructing the left ventricular outflow, and this one is more than 1.5 centimeter. So that's how it's a proper echo diagnosis of this thing, hypertrophic cardiomyopathy. All those this thing is more than 1.5 centimeter. So Takotsubo cardiomyopathy, I think it will keep it for the forum. We have discussed about it. Okay, and transcranial Doppler, ocular. Thank you. Sorry, I took some 2 minutes extra.
Thank you, Piyush.
Yeah, thank you, sir.
I think that was very clear, I think basics. So we'll move to Dr. Hassan, who's going to show us some echoes. I think he's got some interesting echocardiographs here.
I will use the time till they fix the computer. I just want to say I visited many courses of echocardiography, ultrasound. It's not so easy as Dr. Piyush is telling. It's very difficult. You need to take the probe yourself when you have time. Don't drink too much coffee at work. Really, take the probe in your free time and do yourself echocardiography. And really, the only way you learn it, you do it yourself on a patient sleeping in anesthesia or in the ICU. Second point important is if you have a great teacher like Dr. Hassan in your hospital, then this will help definitely. So take the probe yourself, do yourself, and when you have question, ask your senior, and if you have a great teacher, as I said, you will learn it in 1 week. But I didn't learn it in 1 week. So
Okay, no problem.
It will work both ways.
Okay, no problem. Pointer चाहिए pointer नहीं सर ये बहुत हेवी सा लिखा है
Okay. Yeah. May I start?
Yes, please.
Yeah, because to save time, we will try to do as best as we can in the remaining portion of this session. Thank you very much, Dr. Shiv, for inviting me here to come and give some talks, and welcome to all the delegates. It's a beautiful gathering. The gathering is different because you don't have extras here. It's all heroes. No extras. It's all perfect. All are heroes. Okay. Now, I just want to make you feel a bit lighter because Piyush's lecture was very scientific and we were quite engrossed in it. And I always remember for the youngsters before starting any lecture, it's always good to keep your tummy full and your bladder empty. I did that. It's quite some time now. No problem. Okay. Piyush did a great job, and it's like what I did for Piyush. I'm thankful for him to be remembering it. What he took up was his own effort, basically. Still, UK has the maximum number of inventions, but the maximum number of research which is done is in US. So if I have done the part of UK, Piyush is the America. So where is he gone? He's there, yeah. Piyush is the US, because a lot of things which he came up after, I allowed him to play with my probe. Please, don't misunderstand me. I'm sorry. I'm very sorry. Yeah. We have a great gathering here which understands what I am saying. So he did come and played with our eco probe for about 7 days. He picked up the different angles, and if you are able to play well with the probe, you can learn echocardiography, not as easily, because I don't want him to go with that song, Take My Heart Away, like Take My Job Away. So don't take my job away, Piyush, keep my job on, and therefore, now, with all this introduction, I would like to go back and get in with the real talk. And this is how one can, and these are all most of them, 99% are my personal collections of these videos, which you may or may not have ever seen. And you may, if myself, for example, if I have seen it once, I may not see the same thing again in my lifetime. And therefore, you see, these are like case presentations with echo findings, rare once in a lifetime for many. And I work in Al Jahra Hospital, as many of us are here who have been working in Al Jahra Hospital in Kuwait. It's a suburban hospital. It's a secondary stage hospital. We have to send still our patients for cath to another hospital. So we basically do a clinical cardiologist job. And Piyush was a wonderful support for me. He's no more there. He's gone to Dubai to get probably a better company like Dr. Hazim. Now, you see, we as kids, this is Hyderabad, we as kids had heard our own voice echoing from these mountains. But little did I realize that then over a period of around 25-30 years, I will be having an experience of around 25,000 echoes from different hearts, irrespective of their caste, creed, religion or nationality. Now, I owe all my things to my first mentor. I am sure many of you know her in Delhi. This is Dr. Padmavati. She is still alive. She is 97 now, but at 96 she was going to her office. She was the director of GB Pant Hospital. I worked with her in 1975. The other gentleman whom I owe to my second mentor is Dr. Khalilullah. Again, many of you may have heard in the cardiology circles. He has done a great job. He has won awards, and I happened to even meet him last evening, and he gave me this textbook which he has edited, and this textbook is particularly pertinent because he has asked all the Indian ex or present famous cardiologists to write the chapters. One of the chapter is from even Dr. Padmavati, the graceful old lady, and therefore I owe my life or my sort of mentorship to them. Now, starting the job. I'm sure people can make out what it is. Yeah. See, you observe what it is. Piyush has given you the basics, and I'm going to just tell you what things which you actually see through an echo probe. This is a transesophageal echocardiography showing the left atrial myxoma, which is attached from around the left atrial appendage and trying to go right into the ventricle. It's trying to enter the left ventricle, and it has these cases are very often detected in ICUs coming with different problems. And these problems which we have come across directly in our hospital, and Surjiya probably is a witness around here, Piyush is anyway there, that you can in fact get such odd pictures of these myxomas. Patients coming with paraparesis, a part of the myxoma has gone and got stuck into the femoral as a saddle shape. We can get blindness, things can go move there. You can get multi-organ infarcts. In fact, this was a very interesting case which we published in the American Journal of Geriatric Cardiology. 65-year-old lady coming with abdominal pain. She was supposed to have got an ischemic bowel, landed up then into the surgical side. There she developed a chest pain. She got an MI, and we were wondering what it is. Then came the probe. The probe showed a beautiful myxoma. She was sent for surgery, perfectly all right. And I had seen her, in fact, 10 years later as well. You have totally asymptomatic coincidental detections of myxomas. You can have pyrexia of unknown origin, which is one of the common problems they come across, and then you ultimately detect a myxoma. The diagnostic clue with echocardiography, stethoscope has gone into the background, but it used to be once upon a time when we were having only the stethoscope was a changing murmur. That is how we would proceed. Now, are you in the ICU? You can hear the sound there? No. Probably you can't. Okay, leave it. Yeah, see, you are in the ICU. This is another very rare case. Now, as it moves, I will show you that this was a drug addict. Piyush was beside me. Piyush, you remember? Yeah. The drug addict who had come to us. And if you see something very interesting that is happening, there is a vegetation here in the tricuspid valve. And if you see here this vegetation, you will find in the fifth beat, there is something coming out from here. See, these things flowing out. This is an extremely rare catch, where we were able to actually show what is called as a shake-up of the vegetation, and the vegetation actually broke. A part of it broke, and we were able to see that. In fact, thanks to the forum, because we run another forum called the Eco Review Board, where we had put up this case, and an American echocardiographer, a lady, she's the one who pointed out to me that it was surprised that this could be a vegetation shake. I didn't know that term till then, but then you have to be extremely lucky to get that particular moment where the vegetation is actually breaking up. It helps clinically because these things will reach the lung. So one has to be okay. Then comes the next case. Now I have said that, you see, echos sometimes are very interesting in giving shapes. Seahorse. See here, how you can, a seahorse was hanging in the right atrium. Very wonderful. And we were just wondering as to, so therefore we get lots of shapes. When we are doing echos, very interesting findings we can get. And I like giving them names. I had a case which I called it the fetus in the heart. There was a beautiful left ventricular, I think part of it will be shown, no, it's in the other one, where you can actually see a sort of a septum or the sac, amniotic sac, and inside was a lovely thrombus. So I gave the name of a fetus. We had a seahorse, we had snakes, we had mountains and egg. I'll show you the different pictures. Now, this particular thing, now this is Piyush's expertise again. The IVC. But what do you see in the IVC, Piyush? I'll run it again. And even I am time bound. Tell me when it's over. You see this here?
Yeah, that is a thrombus.
In the IVC.
Yeah.
See. It's again a very rare find. You can find a thrombus in the IVC. And please, those who do not have an idea of echocardiography, believe me, call it as a movie presentation and enjoy it like a movie. But it's not difficult to get echocardiography. You take a little time and then you get it. But the basics, as Piyush was telling, in an ICU setting, you can always enjoy it. Okay. Now, next, I'll see. Now, what happened here? It's the anatomy and the physiology which counts in an echocardiography. It's not alone anatomy. As Piyush was pointing out, the hemodynamics. If you are able to compare the hemodynamics with the anatomy, call it yes. If you have a failure on or sort of an anatomical finding with no hemodynamic support, no, ignore, try to. So there will be a lot of situations where you will find that the hemodynamics are the ones which help out. Therefore, anatomy and physiology are both important. Here you had a linear mass and it was a matter of debate. This was a case of antiphospholipid syndrome. IVC and the hepatic veins in the RV study are closely related. And in an ICU setting again, this last line carries a lot of importance because you can get hemodynamics through them. You have yet another one, again another rare, very rare sort of an occurrence which happened. This is the mitral valve, and you can see actually the mitral valve showing an aneurysm. It's actually, it has split, it has broken up and it has split into this portion. So I'll just straight away go next. So you can have in the mitral valve, again when you are trying to do an echo work, is you can have various things, and one of our commonest call comes in through septicemic patients. When you have septicemic patients, we require to show them two things. One is there anything anatomical which is happening there, like vegetations, abscesses which may have been the source of infection, or is it physiology? Because again, physiologically, I haven't, because I can't cover everything in the short period. How the heart moves in a septic. It's called now a sort of a septic heart. And one can, as Piyush was telling, very quickly tell that this is a septic heart. So one has to be aware of what's happening. And Vimohan is shaking his head because he has been following the Facebook so closely, and he has been taking up many of the cases both in ECG side and echo. Am I right, Vimohan? And he may look very, he's a serious person. Yeah. Yeah. Okay. So no murmurs, normal valve, usually not infected. Remember, if you have a normal valve, if you are being called to check on a patient who never had any valve problem, very unlikely that valve is going to get infected. It's usually non-normal valves which will show you infections. And the staff is the worst of the situations. Patients come in a very serious state. Prosthetic valves pose a real challenge in declaring a vegetation. We have issues and problems when we have prosthetic valves. With a prosthetic valve, he calls me in and tells me, please tell me if there is a vegetation. I find similar things hanging there, and I can't tell for sure that this is. So we have two options. Either we do a transesophageal to be more sure on what it is, look into the consistency of the vegetation and the non-vegetative mass, if you would like to call it, because a vegetative mass is going to look, translucency is going to be different in a vegetation than in a non-vegetation. Now, next is this. Okay, this is another very interesting case that happened. I don't know if Piyush was there or not at that time. Hemiplegia. Patient came with a stroke, taken to the ICU, and this ended up with these two masses on the mitral valve. Any guesswork? Piyush, any guesswork? I think he was there. Well, it's very easy to tell vegetations. I agree, it's just vegetations. If it was just vegetations, I wouldn't have put it up here. Yes, certainly. One second. There are two masses, no signs of vegetation, absolutely patient otherwise was normal. Young man came with vegetation, came with a hemiplegia. So we subjected him to further tests, including we got a biopsy out of this, and it was what we call not common fibroelastomas of the mitral valve. There are structures called as fibroelastomas, and these fibroelastomas, I can run them again. So these fibroelastomas, is my time up? Not yet. Ye kya hua? Okay. See now the same one, how it's clapping. See the lovely clap. And this is partly in slow motion we made. And these were called what are known as fibroelastomas of the valves. It can happen on the mitral valve, it can happen on the aortic valve. Usually benign, usually do not cause any problem, but can land up in problems because they have what are called in English as frongs. Those who are from UK and all will understand better probably. Frongs. So there are spaces between the fibroelastomas where the platelets go and get stuck, leading to a thrombus formation, leading to further embolic event, causing the hemiplegia in this particular patient. The clapping mitral valve, the same thing. So, in order to think of vegetation, you need to have the Duke's criteria. There are rare conditions called as blood cyst, fibroblastomas, platelet accumulation in the frongs, surgical removal, histopathology, bilateral fibroblastoma. Now, normally you get unilateral. In this particular case, it was rare enough. I tried to look up at the literature, and I did find that in the literature they have reported even bilateral. Okay, what's next? All right, yes, this is not my video. All others are my collection, even the further ones are my collection. But this particular one, yes, Vimohan. How much is this? I didn't measure it. I didn't measure. See this LA. This gentleman was operated 7 years back for a mitral stenosis. And he came very casually to my outpatient echo day, and when I put the probe, I found this. I said, what is the, no, asymptomatic, Piyush. When I checked, the valve area was not bad, because you see, where is the valve? The valve is somewhere else, outside the heart. So this was a beautiful case, my largest left atrium. And it was, now, yeah, no, this is, yes, before that. Yeah, okay, this is done. Yeah. My largest LA, I did not measure it. There was no need. It was too large. Okay, this is done. Then you have another one. I call it the sad story. It's called the sad story of the ballooning RV. Like Piyush was showing you the RVs. These RVs in pulmonary embolism. You talked of pulmonary embolism, sir. And you talked of pulmonary embolism. And I'll show you the pulmonary embolism. See, post-cesarean, 30 years old female, transferred to ICU with dyspnea, suspected pulmonary embolism. Patient's dyspnea worsening at high speed. They just called in, can you probe this lady? We tried to probe her. Probe showed a real-time RV size increase. Nothing could save the patient. Within seconds, the heart stopped. There was no LV left to be seen. I will show you the video. This is video 1. This is, see here, large. This is the RV. This is the LV. It's not being allowed to move in its way. It just can't do its job. The RV pressure is increasing at a high speed. Large pulmonary embolus. You find that the RV is just getting small. The LV is enlarging at a high speed. And you have a next video. Oh. And you have a next video. I'm sorry, it's not a video. I could only catch this clip because we got too much involved in her resuscitation, in her trying to save her. So, but I could still catch this. Look at this RV. I call it that ballooned RV. And you had literally no LV. Now, here comes your therapeutic aspect. Dr. Hazim was right enough to tell, I'm an old-timer. But we had no time in this case. But remember in those cases, because pulmonary embolism should be treated on suspicion. If you are treating a pulmonary embolism on diagnosis, you are doing your biggest mistake. It has to be treated on suspicion. There's no way. Now, if this or any other where you have a suspicion, and believe me, don't care for anything, bleeding, cleeding, nothing, you need to save the patient. Push 10,000 units of unfractionated heparin. I'm an old-timer. I still don't take the low moleculars so easily. I feel low moleculars are low. I would simply take the, push 10,000 in. Lead, bas, khatam. 10,000 and in. No other option. So, in this case, unfortunately, no time whatsoever. The lady died right there in the ICU. Piyush, I think you were there on this case. Yes, you remember, yes. Huh? That's right, that's right. She wasted some of her time. Sorry for the private practitioners, but she wasted some time in the, okay, no problem. Right, now some of the others, left ventricular thrombus, various shapes, ICU presentations, they may CVA, history of recent myocardial infarction can be there in these cases. Search the LV apex for early features of thrombus formation like fibril formation. Then we have seen changing formations of LV thrombi, follow-up echos are great. You must keep doing echos when you have a suspicion of thrombus or you have extrafibrillary things. Keep doing them, you will find different shapes. Now this particular one is a LV thrombus. I called it the jellyfish. It's the jellyfish here. So anticoagulants work, and these thrombi have by time disappeared as well. Now yet another LV burden, dil to dil hi hai. Ye Piyush ki favorite place is Takatsubo, and Takatsubo is also called the broken heart syndrome. How many he has broken, I don't know, but he likes this particular topic very much. Yeah, he's on a phone, I think, yes. Exactly. And he's on a telephone now, breaking somebody's heart. Okay, Piyush, carry on. Okay, the broken heart syndrome, your Takatsubo. Okay, Hindi movies, वो बेटी भाग जाती, वो दिल पकड़ के बैठ गए, वो खत्म हो गए. So this is where later on the Japanese were the first ones to detect. Takatsubo actually, as he was explaining, it's called the octopus trap. The heart from the up becomes balloon, from low it is normal, so it tries to pump, nothing is going out. The crux of the diagnosis remains with a sudden emotional burden, and which reflects by apical ballooning. They can mimic an acute ST elevation MI on an ECG, so you are in trouble. Do you thrombolize or you don't thrombolize? In the era of PCI, yes, you may take the patient to the cath lab, do a PCI, you find normal coronaries. When you have normal coronaries and a ballooned apex and a young person with emotional trauma, think of Takatsubo. Otherwise, it would be very much like an acute ST elevation MI. You will thrombolize. Where there is no thrombolysis, or rather no PCI available primary, then you thrombolize them. There is no other option. There is no echo. Also you will do, but you can't rule out. Okay, good side, myocardial shape comes back to normal. Dilemma, we tend to thrombolize. Checked. Okay, now this is one of the pictures of Takatsubo. See the upper portion, ballooned. Lower portion, not. This is one picture. I'll show you another one. Yeah. Here I am not too convinced because the movements are good. But still, it was a patient who was favoring this. Now, the snake in the mountains, I'll just go quickly, but let me read this particular slide. It's of importance because what over a period of time, and Dr. Dua was telling about his joining the medical college. I joined in 1965, sir. That's up. अभी बच्चे हो, बहुत टाइम बाकी है, बच्चे हो अभी. ठीक है, दुआ साहब आपसे खास तौर से मैं मिला बाहर इसीलिए. Yeah. So now, but remember, for those who are growing through, please, whatever literature you have, whatever things you go through, keep them. You will never lose them. It will somewhere or the other come to your use. You have to have climb a mountain is not an easy job. Persistence, perseverance, and patience in your job gives an excellent yield. Collect your material. It can be always useful. I collected from echos from still pictures, floppies, CDs, then on to pens, smartphones, and finally, thanks to Mark Zuckerberg, Piyush, and Shiv. And he told me to call him Shiv. Am I right? Okay, thank you. So these brought me here through the Facebook and water walk from 74 to 14. I have not done. Not done. Because the bombshell is still to come. The bombshell is still to come. Look at this, where it goes. Gone. See, I'll show you again. See this. See this, the snake. See where it goes. Gone. Come on. And we have seen them right in front of our eyes. Patient deteriorating, dying, surviving. Either way. Yeah, either. See this. Right atrium, antiphospholipid syndrome case. The mountains in the right atrium. Huge. Okay. Now, this is a borrowed snake from Egypt, I call. I had not seen over a period of 25, 30 years. Please let me take 3-4 minutes more. This were two of the last slides, because these are wonderful. And Dr. Ajay Jindal is the other one who has started this eco review board, and I send in some of my ecos there as and when we feel good. And there are contributions from Americas and the Australias and in between. And there are lots of members who are there. This video clip came from an Egyptian cardiologist, Dr. Rehab Yassin, and with her kind permission, due to its rarity, I borrowed this case. I have seen many of those who have even done occasionally an echo have seen smoke, what we call smoke, or spontaneous echo contrast in the left atrium. Vimohan, watch this. Watch this. Where is this? Yes, where is it? No. If it was left atrium, I wouldn't have put it. I just brought the very selected ones. Watch here. Vimohan and Piyush and anyone. उसके भी और बाहर निकलो. Yes, it's a pulmonary artery, aneurysmal pulmonary artery, very rare. Look at this. I don't know. The video came. Okay, I took it. I asked her permission. Can I put it here? She said, most welcome. So this is one. And then, ultimately, the final use of an echo probe. This is the last slide. Don't worry, I'm through. Now, the final use of an echo probe is what Piyush was pointing out sometimes in situations where patients are dying. I have utilized that occasion. It may look unethical, but on one side there were resuscitations on. But I knew that the patient is going to die. Now, I wanted to know how a heart dies. I want to know what happens precisely when a heart is literally dying. And do we have any relationship to what is called the PEA or the PM, pulseless electrical activity, or the EMDs, electromechanical dissociation? What I found, and I tried to look into the literature also, I couldn't get any. I sent this paper somewhere also. They didn't accept because, I don't know, it was probably thought very, I don't know, but or no literature or something. Now what's happening here? I'll run it again. Oh. Yeah. See what's happening here. This is mitral valve, and that's the tricuspid valve. This is the tricuspid valve, this is the mitral valve. When the heart has already stopped, there was no more contractility, yet these mitral and the tricuspids were moving. I concluded that these are the still electrical activity through the heart causing the pulseless electrical activity on the ECG. You find something, and the nurses very impatiently wait to get into a straight line. The straight line doesn't come. We are restless. We tell them, do something, please, I have to sign the papers, do something. And this. So I think this is one of the possibilities, is that this is what is happening. And with that, this is Kuwait. This is called our Kuwait Towers. These are water tanks actually. These are water reservoirs. And welcome to Kuwait, anyone who wishes to come. Please come and call me up. You will be my guest. And this is Kuwait by night. Thank you.
Thank you, Dr. Hassan.
Any questions, welcome, or let the...
It's lunchtime, it looks like.
Yes. Right. You need a course. How do you assess like, listen. see, regional wall motion abnormality is a very tricky thing. It's not, you see, it's very subjective. Very subjective. It's not objective. To be where you have an MI, which is ST elevation MI, you don't need wall motion, right? You don't need wall motion in an ST elevation MI because your ECG is there showing ST elevation. You don't need markers. You don't need anything. Question comes is non-ST elevation MI. Now, they say till the heart thickness, the wall thickness loses 1/3 of its, or more than 1/3, I think, more than 1/3, there will be no wall motion abnormality. Remember this.
Okay. Well,
So-
what we'll do is, because I was announced that one of our speakers' dad actually had a hemorrhagic stroke last night, so he won't be coming, and that is actually was on a cardiology lecture. So we can actually, you can take some of the questions can be taken on that session, because Dr. Hassan will actually give a talk, bit of it, but we'll have time to actually ask questions, I think. And it is lunchtime, and if possible, can we gather back here by 1:30, if we can? Okay, we'll try to get back here. And I think these sessions have been very interesting. This has been beyond my expectations, actually. This went really, really well. And thank you, Dr. Hassan, very much, and thank you, Piyush.
Thank you, thank you, thank you, thank you. Thank you very much.
Those who have not registered on counter, please sign it on register, because without that you will not get this credit hours. And another thing, those who have not collected receipt, please collect it. Thank you.
Lunchtime, guys.
हाँ, मैं इसे बचा रहा हूँ बैठ से मैं शेट डाउन कर